our first speaker. I have the pleasure and honor to present dear friend and colleague Angela, an amazing neurologist where we practice at the same hospital. Andy's doing a lot of fun presentations throughout the meeting. The first one is in this session, Neuro-ophthalmic mimics of thyroid eye disease. Andy, thank you for being here.
Thanks for having me. You don't have to do neuro-op. You don't. You don't have to like neuro-op. You don't. You don't have to like me, but you have to RESPECT neuro-ophthalmology. Find out what that means to me. Can you load the first slide there? So I'm a neuro-ophthalmologist, as you heard, and so my job is not to make you a neuro-ophthalmologist. My job is to make you know when it is neuro-ophthalmology so that you can get that person out of your clinic and into the MRI scanner. This is your job. Your job is to be a doctor first, an oculoplastics second. Yes? And I think that's something I hope that you'll take away, is that your job is to make sure that you're doing your job. Got the slide up there? If not, we're just going to have to give a talk with no slides. So,
We need the slides, please, for Dr. Lee.
So I'll just start by saying thyroid eye disease. Of course, you all know in this room that the most common cause of eye disease in patients with thyroid is thyroid eye disease. And I'm from Texas. The clicker is not advancing. No go on clicker. Can you just advance it? There's nothing. Only a screen. You want to advance it? So I'm from Texas, as you heard, and maybe you could start the timer too. And these are the snakes of Texas. We have some super deadly snakes in Texas, and no go on the clicker. And you need to be able to tell the difference between a deadly mimic and thyroid eye disease. So these two snakes look exactly the same, except one will kill you and one is harmless. So in Texas we say red touch yellow, kill a fella. Red touch black, friend of Jack. So by the end of this talk you'll be able to know when you come to Texas which of these snakes kills you. Because as a neuro-ophthalmologist speaking to an oculoplastics audience, I need you to test the pupil, the lid, and the motility in every case. Because even though the most common cause of lid retraction in the whole world in adults is thyroid eye disease, and the most common cause of unilateral or bilateral proptosis is thyroid eye disease, once you have pupil involvement, big pupil with big retraction is a big problem. That's cranial nerve 3 palsy with aberrancy. Little pupil with little retraction is also a big problem. That's aberrancy with a Horner syndrome. Big muscles and big pupil, also a big problem. That's something in your cavernous sinus, either carotid cavernous fistula or sphenoid meningioma or something not thyroid. And big red vessels is a big problem. So any of these are big problems. So as soon as you see the lid retraction, yes, you're going to be worried about thyroid eye disease, but you will hear my voice in your head forever. You will never be rid of me. You will be checking the pupil, the motility, and be looking for the distinctive findings in these cases. No, go on, clicker. You're going to have to advance it. And my dad would say, if it looks like a duck and swims like a duck and quacks like a duck, then it's probably thyroid eye disease. Next. Maybe they have that other. Do you have the other? Can you try that? And so one of the things I hope you'll be taking away from lid retraction is, if you see lid retraction and aberrancy of lid or motility, that is third nerve palsy. That is not the thyroid eye disease lid retraction. If you see lid retraction, but there's no proptosis, or lid retraction with no lid lag, that also is something bad. That's usually the dorsal midbrain syndrome. And so it's super important that you check the pupils. Swinging the light and looking for an RAPD is important, but you must look for light near dissociation. If you see light near dissociation, that never occurs in thyroid eye disease. Light near dissociation plus lid retraction is a big problem, and that's usually in the dorsal midbrain syndrome. If it's a kid with lid retraction, thyroid eye disease occurs in kids, but man, is it super rare. You should be imaging all of these patients for lesions in the dorsal midbrain. If you have lid retraction with ataxia, that is a bad thing. Thyroid eye disease does not cause ataxia. And the most common presentation in adults that we see is spinocerebellar ataxia. It has this lid retraction and it looks like thyroid to you, but it's not. You should also beware that if you have lid retraction in one eye and ptosis in the other eye, the most common cause of that is still thyroid eye disease, but you should scan these plus-minus signs. So when you have lid retraction on one side and ptosis on the other side, the differential is myasthenia gravis, or you have a structural lesion in your brainstem. And so these are these pseudo-paranoid syndrome where they have eyelid retraction, upgaze palsy, and it's a lesion in the dorsal midbrain, either the dorsal midbrain syndrome or, in this case, oculomotor nucleus syndrome. And so these lesions need MRIs of the brain. So if you see lid and pupil, lid and motility, lid retraction but no proptosis, these are the imaging things you need to know for MRI in someone who you think has thyroid eye disease. Because even though thyroid eye disease is the most common cause of acute or chronic unilateral or bilateral proptosis, you should be worried it's neuroop if it's atypical. So if it's not quacking like a duck, or not flying like a duck, or not looking like a duck, then you need to scan that person. And so here's a patient who has unilateral proptosis but no lid retraction. We're going to image that. So I image all strictly unilateral proptosis because even though thyroid eye disease is still number one, if there's no lid retraction, that's the one that needs the scan. And you can see here it's a sphenoid wing meningioma with hyperostosis in the sphenoid wing. You need to know that the order of the muscles, as you all learned, is inferior, medial, superior, and lateral. I learned I'm so lucky not to have thyroid eye disease. That is the order of involvement of the muscles. If we have the wrong order, or it's strictly one muscle, it could still be thyroid eye disease, but man, you should be scanning that. Also, any degree of motility deficit other than ET and hypotropia in thyroid eye disease is a big red flag. So if you have XT and ptosis and TED, that's not quacking right. If you have the wrong muscle, so here is the lateral rectus muscle, that's the least likely muscle to be involved. And even though thyroid eye disease can involve the lateral rectus, everybody knows that, it's super weird when it's just the lateral rectus muscle. Don't pick TED here. If you have involvement of the tendon and the gland, or the tendon and the muscle, that could still be thyroid eye disease, but you should be thinking something's in there. And the most common infiltrative thing that we see is IgG4, but it can be lymphoma very easily. It could be any lymphoproliferative disorder. You don't know what's in there. So normally we don't biopsy thyroid eye disease, but sometimes you have to biopsy it when it's not quacking like a duck. You should be aware that conjunctival chemosis, injection, and caruncular involvement, all the classic signs of thyroid and lid retraction. But the thing you're looking for is this, arterialization of the conjunctiva. As soon as you see the corkscrew vessels, that is the big red flag that this is a carotid cavernous fistula. And this is a patient who was referred to me as thyroid eye disease because they had proptosis and they have this enlargement of the superior ophthalmic vein. That is a known finding in thyroid eye disease, but look at all those other vessels there. So if you see any other vessels on the imaging study other than the superior ophthalmic vein, you should be imaging that person. And in this case, it's an arterialized SOV because this vein is actually hooked up to their sinus. And this is the angiogram showing that it is hooked up not just to their orbit, but to their superior sagittal sinus. And this thing is called sinus pericrania. You can see that pre- and post-onyx embolization, they have obliterated this fistula. So in summary, as a neuro-ophthalmologist, I want you to test the pupil, test the lid, and test the motility in every case of thyroid eye disease. Yes, you're going to be swinging the light for a relative afferent pupillary defect, but you also have to be looking for anisocoria and light and air dissociation of the pupil. Any combination of lid and pupil is bad. Big ptosis, big pupil, big problem. That's aneurysm. Big retraction and big pupil, also aneurysm, also aberrant regeneration third. Little pupil, little ptosis, that's the Horner syndrome. We're not talking about that one, but that's a big problem too. Big pupil, little ptosis, third nerve palsy. It doesn't matter what combination of lid and pupil it is, they're all big problems. Even though the most common cause of lid retraction and rhabdosis is thyroid eye disease, you must check the pupil. And if the motility examination is exotropia, not esotropia, remember the involvement of the muscles, it's restrictive. I'm so lucky, the eye has to be turned in and down. If it's turned out, you have a huge problem there. And if you have big muscles and big pupil, you should be thinking about carotid cavernous fistulas, orbital inflammatory infiltrative disease like IgG4, or sphenoid wing meningioma. I image all unilateral thyroid eye diseases because sometimes it's not thyroid eye disease. And you're going to be looking for those vessels. Big red corkscrew. It's okay to have chemosis and injection, but what you cannot have is arterialization. And even though the SOV enlargement is seen in thyroid eye disease, that's the sign radiographically for carotid cavernous fistula. So we are doing angiogram on any SOV enlargement, even if it looks like TED. And you should be aware of the mimics. So now, the next time you come to Texas, you'll know that a black hat with red touched yellow, kill a fella. That's the coral snake, that's venomous. Scarlet nose equals scarlet king equals safe. Red on black, friend of Jack. And I thank you for your time and attention.
Thanks, Andy. Our next speaker is Dr. Serpa on orbital ultrasound, multimodal ultrasound, Doppler, UBM, and high resolution.
Is Dr. Serpa around? If he's not here, we're going to continue with Patricia Akashi. Are you ready? Thank you. We're also doing questions at the end of the session. If you have any questions, please feel free to ask them at the end of the session. Thank you. So, this is Patricia, Dr. Patricia Akashi. She's gonna talk about topical contrast in CT evaluation of the lacrimal system in health and disease.
Okay. Thank you very much. First, I'd like to thank Dr. Luigi and Dr. Daniel for the invitation. And today, I'm going to discuss the evaluation of the lacrimal system with topical contrast enhanced to computer tomography in health and lacrimal obstructive diseases. Well, imaging in lacrimal disease started with daxostography in the beginning of the 20th century, and it became popular because it provided high detail images of the lacrimal system, but it had a limited anatomic information beyond the lumen, as the surrounding bone anatomy, and is not suitable for evaluation of passive drainage. With the introduction of a computer tomography in the 70s, the high definition of imaging was a great advantage of bone and both lacrimal lumen and bone. And with combined with daxostography, it's even better because it becomes, with the new scanners, it allows for three-dimensional reconstruction. However, the higher radiation doses is still a concern. In the 90s, the cone beam computer tomography was developed for dentistry and has advantage of low radiation doses. And for that, it became popular in medicine as well, and especially for lacrimal studies. However, there's a limited availability in medical facilities, and the need for injected contrast agents can be an additional disadvantage, especially in dental facilities. The studies with topical contrast in dark tomography also started in the 90s, especially with this work of Zinreich. Despite of the quality of the images of the first scanners, this study was very important because it shows that the contrast is safe for the ocular surface and could highlight the lacrimal system. Further research confirmed these findings with different contrasts, different protocols of installation, and different volumes of installations. In our study, our experience with multi-slice CT tomography with topical contrast, we also can find good images of the lacrimal system in a passive way in a very short acquisition time of 5 to 7 seconds. And for this procedure, you use the UltraVist. This is a contrast trademark of iodinated, low osmolar, water-soluble, and non-ionic contrast. I have some problems here. Okay, this is our protocol. We start with massage of the medial canthus to express and empty the lacrimal sac. Then we cleanse the eyelid with the saline. Instill 1 drop of contrast medium, the conjunctival fornix every 5 minutes. It means 1 drop per minute, and instruct the patient to blink normally. Once the patient is positioned in the scanner, we put the 6th and final drop. And after the procedure, we clean the ocular surface with saline and discharge the patient. So let's take a look at some results. In this normal patients, normal drainage system without complaints, as you see in the right side, you can see the lacrimal system, the sac, the duct, and even the contrast inside the nasal cavity. And you can see irregularities or regular lacrimal system. And in 20% of cases, you can see air inside the system. On the other side, you have obstruction, a partial obstruction in a patient with epiphora in the left side. Things become more interesting in epiphora and patent irrigation. This patient has a previous diagnosis of functional epiphora because she has epiphora and patent irrigation and eyelid laxity. But with this exam, you can show the stenosis in the duct and stenosis in the duct here, and you can see in the sagittal view the angle between the frontal and the sac and the duct. This helps a lot when you do dacryoplasty and silicone intubation because it can bend accordingly the probe and then avoid false passage. For this patient, we chose this procedure, dacryoplasty and silicone intubation, and after 12 months, she is completely free of symptoms. In obstructive cases, you also can see the dilation of the sac, the level of obstruction, and more than that, you can see the composition of the bone in lacrimal fossa, in terms of maxillary bone and lacrimal bone. You can see the uncinate process insertion in the lacrimal fossa, and you can see the position of the septum and the medial turbinate, which could affect our procedure. In recurrent obstruction after DCR, especially, this is a special indication for this exam. You can see the size of the sac after failure of endonasal DCR. And you can see here agar-nasal cell, which is a ethmoidal cell between the lacrimal fossa and nasal cavity, which is probably the cause of a low ostium here. And this extensive synechia probably was the cause of the obstruction. And you can confirm this before the surgery here. And if you can confirm this, you have this information beforehand, you have less problems during the surgery. This is interesting because in recurrent obstruction with dacryocystitis episodes previously, sometimes you cannot find, with this method, you cannot find the contrast inside the sac. And this can be related to valvular problems, as Rosie-Miller's, or other problems. And probably in this case, it's better to proceed and do the traditional exam, though it may require extra dose of radiation. And then, if you feel much more comfortable and to do a cone beam, if you have a cone beam, because you have less radiation compared to multi-slice CT scanner. So you can have this find without contrast inside the sac, but if you can inject the sac just after this exam, you can see the probable cause of the obstruction or the absence of contrast inside the sac. In summary, the contrast installation is safe for ocular surface. The examination is comfortable for the patient. It provides crucial detailed visualization of the surrounding bone anatomy. This technique serves also as a functional test of the lacrimal drainage system. And if the drop method results in poor delineation, direct inject study should be considered. And CBCT is preferable to conventional CT when possible, of course, due to the significant lower radiation doses. And I'm certain that clinical radiological correlation with new imaging modalities will deepen our understanding of P4A. Thank you very much.
Thank you. Our next speaker will be Dr. Rubens.
Sorry, we do have.
Oh, okay.
No, we do have Dr. Solon Serpa from Peru. He's going to speak about ultrasound, multimodal ultrasound Doppler, UVM, high resolution. He's going to be here with us via Zoom, and there he is. Hello.
Buenos días a todos. Reciban un cordial saludo desde Lima, Perú. Quiero agradecer al doctor Luigi Colangelo por esta invitación. Y bueno, el tema que se me pidió dar para esta oportunidad fue el de ecografía multimodal en patología orbital. ¿Y a qué llamamos ecografía multimodal? Llamamos a la conjunción de la ecografía estandarizada y la ecografía de alta resolución y Doppler, que la vamos a obtener a través de los equipos de ecografía general. La ecografía estandarizada, como oftalmología, es el estudio ultrasonográfico estándar en la patología ocular y orbitaria, pero tiene tres deficiencias. Tiene escasa penetrancia en el vértice orbitario en modo B, no logra imágenes de alta resolución en la órbita y no proporciona un estudio ocular cuantitativo del MIN, lo cual lo podemos resolver si es que le agregamos la ecografía de alta resolución y el Doppler. Pues podemos hacer uso de la elastografía, que es otra modalidad de ultrasonido que se usa para diferenciar tumores benignos y malignos. Entonces, la ecografía multimodal es un excelente complemento de la tomografía y de la resonancia magnética nuclear. ¿Y cómo funcionan estas tecnologías de ecografía general a nivel de la órbita? Bueno, estos ecógrafos usan transductores lineales multifrecuencia, los cuales nos van a permitir obtener imágenes de muy buena calidad, de alta resolución a nivel de la órbita, desde la piel de los párpados hasta el vértice orbitario, obteniendo imágenes enfocadas a diferentes profundidades. Como pueden ver en esta imagen, un meningioma de la vaina del nervio óptico, vista por ecografía de alta resolución y por resonancia magnética nuclear. La resolución espacial de la ecografía es superior a la de la resonancia y la tomografía. Por otro lado, estos dispositivos, estos traductores lineales multifrecuencia, tienen mecanismos Doppler, para hacer estudios cualitativos a través del Doppler color y el Doppler poder, y también un estudio cuantitativo a través del Doppler espectral, con lo cual podemos medir los flujos en centímetros por segundo. Vamos a ver algunos casos de tumores orbitales. El meningioma de las vainas del nervio óptico, que ya demostré, que en el estudio Doppler evidencia flujos muy débiles intrínsecos. Nosotros en los últimos 3 años, cuando solicitamos tomografía o resonancia, ya no pedimos con contraste, ya que el estudio Doppler nos permite un estudio vascular mucho mejor que los estudios contrastados de resonancia o tomografía, y nos sirve mucho para hacer caracterización de los tumores y también nos ayuda mucho en la planificación prequirúrgica. Otro caso de meningioma de las vainas del nervio, estudiado por ecografía estandarizada, en modo B, ya estandarizado, pero fíjense cómo se complementa el estudio con las imágenes de alta resolución y el Doppler. Fíjense cómo se ve con alta resolución la silueta del nervio óptico, la del tumor, y el Doppler nos manifiesta que hay flujos débiles intrínsecos. Un caso de glioma nervio óptico estudiado por ecografía estandarizada, modo B ya estandarizado, y cómo lo complementamos de forma efectiva con ecografía de alta resolución y Doppler. Nuevamente en este tumor, el Doppler nos dice que el tumor tiene flujos débiles intrínsecos. Los linfangiomas, paciente de 10 años, estudiado con ecografía estandarizada, pero fíjense cómo la alta resolución nos permite evaluar la silueta tumoral desde la porción posterior del globo ocular hasta el vértice orbitario, y el Doppler nos pone de manifiesto la vascularización de los tabiques, ¿sí?, de este tumor. Otro caso de linfangioma, en el cual vemos una lesión con zonas quísticas, hipoecoicas, con tabiques hiperecogénicos, que al Doppler manifiestan vascularización, con lo cual apoya el diagnóstico ecográfico de linfangioma. Niña de 3 meses, que en la consulta el ecógrafo nos ayuda a hacer un diagnóstico preliminar de hemangioma capilar orbitario. Esta diapositiva es muy interesante porque nos pone de manifiesto qué tan valioso es el Doppler. Tenemos 3 casos en los cuales se evidencia una imagen de muy baja ecogenicidad en la órbita anterior y en el sector paraocular. Fíjense que los dos primeros ecogramas manifiestan una lesión ovoidea anecoica, y la tercera el componente mixto, con un sector anecoico y un sector anterior heterogéneo. Fíjense cómo en el Doppler la primera lesión no capta contraste intrínsecamente en la lesión. En el segundo caso sí hay captación de flujos intrínsecos en esta masa. Y en el tercer caso, en la porción anecoica no capta contraste, pero sí en la porción heterogénea. ¿Y por qué es eso? Porque el primer caso constituye un quiste de inclusión, el segundo un linfangioma, y un linfoma, y el tercero un schwannoma mixto. También esta tecnología aplicadas a la órbita nos pueden ayudar a hacer diagnóstico de varices orbitarias, y cuando tengamos esta imagen presunta de una fístula carotidio cavernosa, podemos hacer ecografía a modo B ocular, en el cual podemos apreciar la dilatación de la vena oftálmica superior en corte longitudinal y corte transversal, y el estudio Doppler color nos evidencia una vena oftálmica superior con flujo invertido, que al medirlo nos evidencia un flujo arterializado de esta vena oftálmica superior. Inclusive podemos medir el flujo en el cual el resultado fue de 12 centímetros por segundo, haciendo un diagnóstico en el consultorio de fístula carotidio cavernosa. Como ustedes saben, el ultrasonido al atravesar el hueso se genera el fenómeno de atenuación. Generalmente a través del hueso nosotros no podemos ver estructuras por ultrasonido. Pero fíjense cómo estas herramientas actuales nos permiten, en este caso de un carcinoma epidermoide del seno maxilar, poder evaluar por ecografía todo el contenido del seno maxilar con un componente heterogéneo y un estudio Doppler evidencia flujos anárquicos, ¿sí? Con lo cual apoya el diagnóstico de una noticia maligna. Y también nos va a servir esta ecografía multimodal para hacer seguimiento postoperatorio. Por ejemplo, aquí tenemos un quiste hidatídico orbitario que se encuentra en el cuadrante nasal superior, en el sector retroocular. Aquí una ecografía en corte transversal, tenemos el globo ocular abajo y por encima el quiste hidatídico, y a la derecha el corte sagital de ecografía. Se hizo una intervención a través de la conjuntiva fornix nasal superior, se llegó al quiste, se aspiró un líquido cristal de roca y se inyectó hipersodio y se dejó por 15 minutos antes de resecar la lesión. Aquí está el contenido quístico con el sedimento blanquecino y se procedió a retirar el quiste hidatídico. Posteriormente, el paciente fue evaluado cada 6 meses para seguimiento y en las consultas de control se realizaba ecografía de alta resolución en busca de recurrencia del quiste sin evidencia durante los siguientes 3 años. Este paciente acudía con una masa orbitaria superior que en la ecografía estandarizada nos evidenciaba una lesión de muy baja reflectividad, con lo cual pensamos que tal vez se podría tratar de una lesión quística. Sin embargo, el estudio Doppler, como ven en esta figura inferior derecha, evidenciaba flujos muy débiles intralesionales, con lo cual concluimos de que se trataba de una lesión neoplásica de muy baja ecogenicidad y baja vascularización. Se procedió a hacer una resección tumoral y se obtuvo un schwannoma. De la misma forma, el paciente fue evaluado cada 6 meses en control de consulta oftalmológica y se realizaba ecografía de alta resolución en busca de recurrencia. Para el seguimiento de los pacientes que son sometidos a resección tumoral, la ecografía nos da constituye un buen estudio para determinar si hay recurrencia. Tan solamente en el 5% de los casos requerimos complementar con tomografía o resonancia en busca de recurrencias, lo cual hace una herramienta de mucha utilidad en la consulta diaria. Entonces, como conclusión, la ecografía multimodal es la mejor herramienta para la evaluación ultrasonográfica de la órbita para obtener mejores diagnósticos, mejores decisiones de manejo, mejores decisiones terapéuticas, para una mejor planificación quirúrgica y para un mejor seguimiento. Muchas gracias.
An update on state of the art of orbital endoscopy.
Thank you very much. Thank you very much, Luigi, for this. Well, I have to speak about the state of the art of endoscopy of the orbit, and I think that the real state is that almost no one in oculoplastics are using endoscopy for orbit, and we have to change this. And I want to share with you some tips for you to begin your learning in endoscopy. The most difficult part is you have to use a device and you see a bidimensional image, and the orbit is three-dimensional. And so you have to learn how to read this, because it's very easy to get lost in the orbit. So you have to learn the anatomy to recognize some landmarks to don't get lost in the ethmoid. And you have to read the CT scans as you were an ENT surgeon and not an ophthalmologist. You have to be an expert reading CT scans, and this is very useful because what you have on the CT, you will be able to see this in your surgery. And you have to recognize some landmarks. The first is, this is the maxillary line, this is the medial turbinate, this is the nasal septum, and you have a very strong line, this is the maxillary line, here is the lacrimal, and behind is the uncinate process. The uncinate is here, is the first part you have to remove to access the most important landmark, that is the infundibulum. The infundibulum is a three-dimensional space when you will find the ostium of the maxillary sinus, you will find clearly the anterior part of the ethmoid, that is the bulla ethmoidal, and in some cases you will find the drainage of the frontal sinus. We have to open the uncinate process to access to the infundibulum. We remove the uncinate process, and then we will be able to see the structures. The big one is the bulla ethmoidalis, and the most important part is you will find this oval structure that is the drainage of the maxillary sinus, the ostium of the maxillary sinus. Why is it important? Because when you find the ostium is in line with the inferior part of the bulla, you will be able to open, widely open, and then you will see the roof of the maxillary sinus, and then you know where the orbit is. So it's very important to find this structure at first in your surgery. This is the way we make our antrostomy. We have to obtain as large as possible so you can clearly see the maxillar sinus. And we are removing the ethmoid bulla. We always enter through the inferior part and from the medial part, because it's the safest way to do this. We don't have to make an injury of the skull base or the orbit. Then the natural intuition is to go over there to remove the remaining of the anterior ethmoid, but you always have to keep in the inferior part. You have to go to the posterior ethmoid through this structure that is the basal lamella of the medial turbinate. The medial turbinate has an attachment to the papyracea. This is the basal lamella. You will find very easily because it's attached to the turbinate, and through the basal lamella you go on and continue your surgery. Not the upper part. Keep low. These are the structures you have to see. You have to be an expert reading the sagittal scans. This is the drainage of the frontal sinus. This is the agarnacy, and the posterior part is the bulla. The bulla is your first lamella. It's the anterior part of the ethmoid you have to remove, and then you don't go in this part because you can make a fistula. You ever have to be in the lowest part to access. This is the basal lamella, this is the medial turbinate, this is the attachment, and through the basal lamella you go to the posterior ethmoid. Then you can remove the remnant, seeing the skull base, that is the most dangerous part of this surgery. You don't have to injure the skull base. This is the way we go through the basal lamella to to gain access to the posterior ethmoid. When you are in the posterior ethmoid, you will see clearly the inner wall of the orbit. Always remember that your endoscope, you enter in this way. It's very easy to go to the spool base. You have to keep in the lowest part as much as you can to have a secure access. So we are in the posterior ethmoid, and then we'll remove the remnant of the anterior ethmoid. You have to completely remove all the ethmoid to have space to decompress your orbit. We are using a device that is like a vitrectomy device to gain time. Then you will see the inner part, and here we are opening the sphenoid. It's not necessary to open the sphenoid, the rostrum sphenoidal, because you don't have to do this in your decompression. I did this for academic reasons, to see that it is possible by endoscopy to remove part of the optic canal when you need to do this. From the endoscopy, you can remove always the medial part of the floor. This is important when you have an uncompressive optic neuropathy. And this is very useful. It's hard to remove because the body is very hard. And this is the most difficult part. You can do it through the conjunctival access, but you can do it by endoscopy. We are removing the posterior part of the floor because in optic neuropathy, the posterior part of the muscle is when we reach the most enlargement. This is the sphenoid. So we are removing the most posterior part of the floor and the optic canal. When you are seeing all the inner wall, you have to remove the bones. The posterior part is the hardest. The anterior part is easy because the papyrus is very, very thin. So this is the maxillary sinus, this is your orbit, and you have very good visualization of the structures. This is the useful of endoscopy. Then you have to open and remove all the periorbita, and then we will see the enlarged muscle, very large one. This is a very severe optic neuropathy, and you will see the muscle as you've never been before. You have to remove all the periorbita, and you will be able to see your superior and your inferior muscle. In cases that are not compressive neuropathy, when you remove the periorbita, you will see only fat and not the muscle. The muscle is easy to see them in the posterior part. In the anterior part, you always see only fat. So these are the structures you have to recognize. You have to study all the lamellas, and remember that the Uncinate process, that is your first door to gain access to the infundibulum, can have 3 attachments. You will find the Uncinate process in the tomography continuing the inferior turbinate, and you have 3 kinds of attachment. If the Uncinate process attached to the medial orbit, your frontal sinus will drain directly to the middle meatus. But if it is attached to the spool base or to the medial turbinate, the drainage of the frontal sinus will be in the infundibulum. So the infundibulum is a very important structure in the physiology of the maxillaries and frontal sinus. So remember, you have to to know very well and to understand the osteomeatal complex, the infundibulum, the middle meatus, the oncinecrosis, the bulla ethmoidal. These are your important landmarks in endoscopy. And you have to remember that you can have a high attachment of the skull base, or a very low or a very high, and the anterior ethmoidal artery could be in the skull base or along in a mesenterium. And you have to remember that you can have some structures called onodi cells. Never in the sphenoid you have to have some horizontal structures. If you have an horizontal structure, this is ethmoid, this is not a sphenoid. This is a pneumatization of the ethmoid through the sphenoid. And the danger is you can gain access to the skull base. Okay, so spend some time studying in the workstation to be an expert reading CT scan, and spend some hours with your ENT surgeon to know how to manage the bleeding, how to get at the correct position, and to get understand the vision of your surgery. If you don't have any ENT surgeon friend of you, you can reach in the parking of your hospital. This card is for the neurosurgeon. This is for the retinal surgeon. This could be the ENT surgeon, and this is yours because you are oculoplastics. Well, thank you of all Italian doctors to be a friend of Daniel. You saved the life of Daniel, and especially Luigi, and Daniel loves all of you. You were like a brother with him. Thank you very much.
Castella. He's gonna talk about. Sorry, can you hear me? There. Guillermo Castella. He's gonna talk about management strategies for orbital lymphatic venous malformations.
Thank you all. Good morning. First of all, I would like to thank Dr. Luigi for his kind invitation to return to this wonderful Amalfi Coast, and also Daniel Weil for all his knowledge that he passed to us, and also for this Congress. So I'm going to speak a little bit about management strategies for orbital lymphatic venous malformations. We know that orbital venous lymphatic malformations are rare, benign, slow flow, and combine venous and lymphatic components. They overall correspond almost to 4% of orbital tumors. Normally they are congenital, or they manifest in childhood, the majority before 6 years old, and the clinical presentations is variable. Most common is the proptosis, but you can have a recurrence of hemorrhage, ocular motility restriction, eyelid edema, ptosis, and also visual deficit. The behavior is infiltrative, encapsulated, it's highly vascular and recurrent. That is its problem, and gives us lots of problems and complications when treating these patients. We have recurrent orbital hemorrhage, it's frequent even in children, pain, decreased vision and possibility of amblyopia, restrictive strabismus, exposure keratopathy, and compressive optic neuropathy, and also a cosmetic disfigurement that patients don't like. They pose us also a very difficult challenge when we try to treat them. We have mainly three options of treatment: surgery, systemic agents, and sclerotherapy. We know that surgery treatment is many times with suboptimal results, and sometimes we try to be conservative and to follow these patients, but it depends a little bit on what patient we have. And this is what I'm going to show you. I will show you different clinical cases with different approaches in our clinical practice. This is a young patient that we were able to completely surgically remove the tumor. It was a 10-year-old patient with spontaneous subconjunctival hemorrhage. inferior eyelid ecchymosis and proptosis of the right eye. She went to our emergency room. Vision was fine. She had an intracorneal lesion that you can see in the image of the MRI between the medial rectus muscle and the optic nerve. It was very circumscribed and encapsulated, so we decided to do surgery. After a week of steroids, we decided to do surgery with a supramedial anterior orbitectomy and through the upper eyelids crease, and we were able to remove all the tumor with no recurrence, and these children, after 7 years, she's okay with no recurrence. This is a long-term management patient, a patient that was diagnosed of the lymphatic malformation at 8 years old, and then he has like 2 episodes of recurrence with hemorrhage and mainly after upper respiratory infection. And so he had 2 episodes of severe proptosis with hemorrhage, one at 22 years old and the other one at 26 years old. The image you see is the last recurrence. He had a big recurrence with big proptosis and risk of visual loss. He has also a limitation of abduction and elevation of the left eye. We did 2 sessions of bleomycin with 2 millimeters, 2 mLs, one in the first section and 1.3 in the second section. And then afterwards he was stable and we removed the reminiscence of the conjunctival lesion that you see in the middle image that was removed, and this is how it is now. And but so far, no recurrence after 2 years. You can see that he still has a left intracorneal reminiscent lesion after the sclerotherapy, but doesn't. It seems it's sclerosis, not active lesion. This is another case of more follow-up that we approached with a multimodal approach. It was a patient that started with, he was born with a lesion, as you see in the first image, but at 18 months of old, he had a very big hemorrhage with a severe proptosis, and also he had an extension of the lesion to the mandibulary area. We started with propranolol, but it didn't respond, as we know. So at 18 months, we decided to do, because of the risk of the vision loss, we decided to do intralesional bleomycin, 1 for the orbital component and 4 for the maxillomandibular component, with total of 8 ml till now, and he's fine. Also, we decided to start with oral sirolimus for 3 years, and till now he doesn't have any recurrence, but still has some lesions at the mandibular area. The eye is better than the mandibular area. We know bleomycin is an antibiotic isolated from Streptomyces verticillus. It's an anti-tumor agent. It has a sclerosing effect on endothelial cells and a non-specific inflammatory reaction that follows fibrosis and involution of these lesions. That's why we use it. This is the doses we use it. In children under 1 year old, we use it this dosage. When we do for children older than 1 year or adults, we use 1 to 15 milligrams per session. We re-inject normally after every 4 weeks, and sometimes we have to do more than one session. The medial dose is 3 sessions. This is how we do it. Using ultrasound guidance, we use the 23G needles and insert in the malformation, and we try to aspirate the blood and the lymph, as you see. So it's better when we have a very big macrocyst. We can remove lots of blood and lymph. Then we can use fluoroscopy, can be used to ascertain the correct needle position, also the anatomy and the venous drainage, and to see if it doesn't go to the venous sinus. And then slowly we inject the bleomycin. We inject in syringes of 1 ml, 1 milligram for 1 ml. Normally we inject the volume that we remove of the lymph and blood. And we do it percutaneously in the majority of sessions. This is also another case of a refractory venous lymphatic malformation. It is a 53-year-old patient that was diagnosed at age 29. He had intermittent episodes of hemorrhage during his life that were dealt with surgeries in other centers and also steroids. The venous lymphatic malformation, as you see, is mostly intraconal and has a macrocystic and microcystic component and is stretching the optic nerve. So we decided to do one session of bleomycin, and we see that we had a transient reduction, but still we do have we maintain a big lesion. So we decided to do sirolimus, and he started sirolimus and he's doing for 1 year sirolimus. He had a new episode of a small episode of hemorrhage that we controlled with steroids, and he's like this now. So no recurrence so far since he's doing sirolimus for 1 year. So this is a patient we did both therapies. We know that sirolimus is an inhibitor mTOR. He inhibits lymphangiogenics and endothelial proliferation. He reduces the size mostly of the lymphatic components, and normally we use it in refractory cases, especially microcystic lesions. That's where he functions better. Typically, we administer it orally, with cases reporting success with doses. Normally, the dose we use is 1 milligram twice a day for at least 6 months. And this is another final case just of clinical observation. It's a patient of 34-year-old that was diagnosed at age 10. He had intermittent small, low episodes of hemorrhage during infancy with intermittent diplopia, but it's stable. So it has a multi-lobed lesion in the right orbit with intralesion and intraconal and extraconal components. And this patient, we managed it, he had no progression, so we only observate these patients. So this helps us to see a very heterogeneous presentations. We have pediatric patients that mostly have acute pediatric hemorrhage and infection related exacerbations versus the chronic relapsing adult disease. Also, the pattern of radiology is very mixed. We have mixed components of lymphatic and venous lesions, heterogeneous signals with variable enhancement after contrast, and mixed intraconal and extraconal involvement. So it's very variable. Also, there's a variability in management. We can have conservative monitoring when we have stable lesions. Surgery is successful only in well-circumscribed lesions. Bleomycin sclerotherapy produces favorable, sustained responses in most, but normally suboptimal results in microcystic disease. And sirolimus we use as a rescue therapy, improves outcome in pediatric and adult patients, but mostly in microcystic disease. The long-term follow-up, we expect recurrence and progression, so we have to follow these patients for a long time. In conclusion, I would say that orbital venous lymphatic malformations required multimodal, stepwise algorithm guided by lesion characteristic and multidisciplinary collaboration. We know that surgery and/or bleomycin remain core treatments for well-defined and macrocytic disease, and sirolimus provides meaningful stabilization in diffuse or microcystic disease refractory to other treatments. I would like to invite you to our ESOPS annual meeting that is going to be for the first time in Portugal, in Cascais, in September. Hope to see you there. Thank you for your attention.
Up here if you like. Thanks to our speakers, we're actually only 7 minutes behind, maybe now only 6 minutes behind, so even though we started late. We're going to go into the rapid fire section of this session, and I'd like to invite our first speaker. Please write down your questions. We will have time for discussions at the end. We'll go over every presentation and ask for questions. I think we should have time. So our first rapid fire case is by Dr. Luna Rodriguez, ultrasound and oculoplastics.
Hello, good morning. Thank you, Luigi, for the invitation to participate of this Congress. It's always a pleasure to come to this beautiful site with all of the friends that we've made through the years. So today we're going to talk about the use of ultrasound in our practice in oculoplastics. Some years ago, I started having this kind of patients who had treatments with hyaluronic acid in other centers and were having some issues with it. So they came to my clinic to have those problems solved. So around that time, I saw a very nice talk of Josie Kohn about the use of ultrasound. And I started using it. So I do usually use it for this kind of patients who come to my clinic, for example, with edema derived from these treatments. And sometimes they've had already 3 or more rounds of hyaluronidase and they can't solve it. So when we do this procedure guided by ultrasound, we can be much more effective. We can see what we're doing. We can see where the hyaluronic acid deposit is situated, and we can treat it much more effectively. We can also use it for this kind of patients. Patients that come to our consult seeking for lower eyelid blepharoplasty. But sometimes when we're doing our examination, we can see that something is odd, something is not like always is, and we can see a certain discoloration, and we have certain doubts. Is it a lower eyelid bag, or is it something else? So for these kind of patients, I think the ultrasound also is a big help. When we're using the ultrasound, we can see the hyaluronic deposit. We can see where it's situated. It's an hypoechoic mass, and usually it's pretty easy to identify. Also, when we're doing the ultrasound, we have different modes, and when we use the B mode, we can make it differentiated from the vessels, because the vessels are also hypoechoic, and we can check for the vessels around the deposit. We can also use it for vascular mapping. This is very important because when we do our treatments, we want to make sure that we're going to have problems like this one, which are like the nightmare of every doctor who performs these treatments. So if in the case that we did have this problem, also ultrasound is going to help us to solve this problem much more effectively. What can we use ultrasound for then in our practice? It's very useful to make our diagnosis more accurate. We can use it for vascular mapping. We can use it to make our infiltrations assisted by the ultrasound. We can always use it to manage complications, and always also for education and research. So if you do not have ultrasound in your office yet, these are the things that you should look for in your device. High resolution. This is 4 centimeters depth, so that you can use it for everything you need. Something easy to use, intuitive, portable, no cables, and with AI assistance if you can. In conclusion, ultrasound has become a key tool, especially in oculoplastics if you have aesthetic practice. It allows us to have more information. It does have a learning curve. It is something that you need to know, but always knowledge is power. Thank you very much.
Our next speaker is Dr. C.B.
Don't worry.
DeSantisiachi. She's going to speak about preliminary study of... Can we have her slides?
Hi, good morning. Thank you for the opportunity. I'd like to thank the scientific committee. Today I wanted to show you an innovative test for ocular motility that we are implementing in our daily practice. The Virgo is the virtual interface for real-time gaze oculometry. But first, I just want to quickly remind you what is the Hess-Lancaster test. This is a diagnostic test for the quantitative assessment of ocular motility and binocular alignment For this test, the patient wears these red and green glasses. It faces a screen that usually is at 1 meter of distance, and the examiner has a pointer, and the patient has to superimpose his flashlight onto the examiner flashlight. And this test is needed to identify the paretic muscle in the acute phases. For this reason, the Virgo, the virtual interface for real-time gaze oculometry, was conceived to be an advanced and reliable substitute for the classic Lancaster test. As you can see on the left side of the screen, the patient has to wear this virtual reality headset that projects 4 different screens and keeps in his hand this joystick that has a button, and he has to virtually point the light into the screens. So this achieves an automatic and precise diagnosis and ensures higher precision. For these cases, of course, the indications are the same as the classic Lancaster test, so the paralysis of the oculomotor nerves, the blowout orbital fraction, myasthenia gravis, but for these cases in specific, it was thought to be super helpful in polytraumas and in general bedridden patients, but also paving the way towards telemedicine. This is the platform. As you can see, we can add each patient, and for each patient we can add different visits, and also we can add different documents, such as, for instance, the medical history of the patient, but as you can see there, also the classic Lancaster test. So we had a cohort of 20 patients with extrinsic ocular muscle pulses who were administered traditional manual Lancaster test and also the virtual reality Lancaster system. And thanks to the automated virtual reality calibration and the cloud synchronous data, we had a comparison between the two, and a diagnostic consistency was obtained. Just 2 different kind of cases. You can see on the top of the screen the virtual reality test, which was then confirmed by the manual test. Also in these cases, so Virgo proved to be quite accurate in diagnosis of extraocular muscle pulses. And indeed, it proved to be faster than the regular Lancaster test, and the clinical interpretation time was reduced by 60%, so it led both of the methods yield to a very strong correlation between the deviation map. So we can consider Virgo to be an avant-garde tool to help our daily practice, but especially in bedridden patients and also polytraumas, but also paving the way towards what is the new telemedicine for use, and also to new frontiers of specialized care, integrating new affordable and up-to-date devices. Thank you.
Okay. Our next speaker is Dr. Ciccarelli. He's going to talk about upper transpalpable endoscopic approach for orbital dermolysis, a minimal invasive technique with optimal aesthetic outcomes.
Good morning, everyone, and thank you for the opportunity to speak at this beautiful congress. I'm Dr. Maria Cristina Ciccarelli, and I'm from the maxillofacial unit surgery of the University Napoli Federico II. Today, I will present our experience with the endoscopic transupper eyelid approach for the treatment of orbital dermolysis, focusing on its minimally invasive nature and its excellent, beautiful aesthetic outcomes. Orbital dermolysis are benign congenital lesions frequently located in the supratemporal quadrant and commonly diagnosed in young patients. These lesions have been treated by the years with external approaches. However, in recent years, the endoscopic transupper eyelid approach has emerged as a valuable alternative because it guarantees better outcomes and at the same time with reduced surgical invasiveness. We report the case of a young patient presenting with a mild lateral swelling of the left upper eyelid. The lesion was slow growing, but at the same time symptomatic. as the patient experienced severe headaches, which lead to further investigation with MRI. Images confirmed the diagnosis because in the images of the MRI there were preoperative images. The representative preoperative MRI images clearly showed the lesion's location and its relationship with the orbital lateral wall, confirming the diagnosis and guiding the surgical planning. So the video. Okay. Here we demonstrate the surgical technique. We can see that a little incision is made in the upper allied natural crease, allowing beautiful cosmetic results. Through this incision, we can approach to dissection, preserving the surrounding structures. The endoscopic visualization is crucial because it allows and provides magnification and illumination. The cyst is progressively exposed and completely removed. Finally, the incision at the end will be closed with minimalist care. The post-operative course was uneventful. No complications were observed and the patient achieved an excellent aesthetic outcome. At 3-year follow-up, no recurrence was detected. At the conclusion, we can say that the endoscopic transupper eyelid approach is today a valid minimally invasive alternative for the treatment of orbital dermoid cysts. This approach consensus the radicality. Yes, this approach is particularly advantageous in children and young adults because they are more prone to recurrence. Thank you for your attention.
Thank you. And finishing up with the morning session, one of my colleagues from Wills, Dr. Pedrosian, on the oculocardiac reflex in an empty orbit. Ed?
If the speaker joins us in the next few minutes, let us know. But we're just going to go right into the discussion session. I'm going to call on each speaker and then ask you to ask questions if you have any. Our first speaker was All the Teaching Pearls by Dr. Andrew Lee. I never get tired of listening to Andy. So any questions for Andy?
So I actually have two for you. The first is, in a patient who has classic thyroid eye disease, all the findings, and is a big SOV on imaging, but no vascular findings on exam, do you still go after workup for CC fistula? And the second question is, if you have these confounders of conjunctival injection and so forth, your workup for CC fistula, do you go straight to an agram or do you bother with a CTA and an MRA first?
But just go ahead and start with the non-invasive imaging first because it would establish the diagnosis. But if it's negative, you're going to have to go to the gold standard. So when would you do an angiogram on thyroid eye disease? I would not do it if it quacks like a duck and looks like a duck and flies like a duck. I would do it if it's unilateral, wrong muscles, SOV enlargement, any vascular lesion outside, cavernous sinus fullness on the non-invasive study. MRI is normally what we would start with. All of those are getting a standard catheter angiogram. Normally the distinctive finding is the corkscrew vessels, but you need to be aware there's this white-eyed version of it called a white-eyed shunt, where there's no redness of the eye because the thing is posterior draining. That one can have big muscles, proptosis, sixth nerve palsy, no redness. So I guess it has to be individualized, I would say.
But the bottom line is you don't think a negative CTA and MRA conclusively rules out a fistula.
That's correct. So if you have a negative CT, CTA, but you still think it's a fistula, you have to go to the gold standard, which is standard catheter angiogram.
Great. Great, thank you. Our next talk was virtual, Dr. Serpa. Any questions for Dr. Serpa? Although I'm not sure if he's on. We can. Yeah.
You touched quickly on a very important point about the case with significant ptosis on one side and significant retraction with lid lag on the other side. So can you elaborate more on this, how to differentiate between just reciprocal innervation? If you said you should look out for myasthenia and...
Yeah, so that combination of findings, a ptosis on one side with lid retraction on the other, we call that the plus-minus sign. So the plus-minus sign means lid retraction is the plus and ptosis is the negative. So it's a plus-minus sign. The thing you worry about there is the plus-minus syndrome from the plus-minus sign. The plus-minus sign is sometimes because you have a lesion in the midbrain causing ptosis on the one side and the Collier's lid retraction sign on the other contralateral side. So we image the true plus-minus sign. However, the most common cause of the plus-minus sign is pseudo plus-minus sign because, as you know, if you have ptosis on one side, you might get pseudo retraction on the other side, or you might have true retraction and pseudotosis on the other side. So the first thing you're going to do is lift up the ptotic lid and see if the lid retraction will go down because of the bilateral innervation to the levator. So if you lift up the ptotic lid and the retracted lid goes down, that is a pseudo retraction, that is a pseudo plus-minus sign, and that means you don't have to image that. However, our most common cause in thyroid eye disease is that you have concomitant myasthenia gravis. The two disorders are autoimmune mediated. About 5 to 15% of patients have both myasthenia gravis and thyroid eye disease. So the combination of ptosis and lid retraction, if it's true lid retraction, you should work that patient up for both myasthenia gravis and thyroid eye disease.
Excellent. So for the topical contrast enhanced CT evaluation of lacrimal system, I have a question for the speaker, but are there any questions for that talk? I might ask my question. I was curious about how you came up with 1 drop per minute times 5. Just maybe you can comment on that. How is that better than any other sequence of events? And then, do you do this in the CT scan suite? Because obviously, it sounds like you have to just be ready to do the images as soon as you put the drops in. So tell us a bit about the logistics of how you do that. Yeah.
Thank you. So this protocol is because of the literature and because the normal size of the lacrimal sac accommodates 0.2 ml of contrast. That's why we try to reach the minimal doses for comfort of the patient, because we start with the normal patients. So after 2 meters, normally they feel the sensation, the taste of the contrast. And absolutely, you have to be ready to do the exam. So you have to stay close to the scanner and start your administration. 1 drop per a minute, and then the patient sit down, and then after the 5th drop, you go to the scanner and accommodate the patient and put the last drop and proceed to the exam.
And Patricia, if somebody has a known IV contrast allergy, can you still use this technique or no?
Well, it's a contraindication. If the patient has no allergy, you cannot use this technique, and you cannot use the contrast, iodinate contrast.
Have you encountered any local irritant effects from the iodinated solution?
I mean, effects in the side of the cornea. Yeah, the first phase of these studies regarding this aspect is no complaints, no problems. We control the ocular surface in the biomicroscopy, and there's no side effects.
Any questions for Dr. Rubin? That was a great talk. Any questions for Dr. Rubin? There were a lot of nice anatomic pearls you taught us. Ganga?
Actually, compliments on the entire session, beautiful talks, and I loved your talk in particular, correlating radiology and intraoperative findings. Where do you divide the line between allowing the ENT surgeon to work with you versus you doing the procedure versus working as a team universally? Because there's a diplomacy, medico-legal aspects. If you can reframe the question in Espanol.
He's asking, when do you, just pass it on, when do you do the case, the whole thing yourself, versus you combine with ENT? I think that's the gist of the question.
Nowadays, I'm performing all by myself. I learn with the ENT. I learn at the same time that the ENT learns in 1996. It's important for you to do your first steps with an ENT, because you will be more confident, because you have to learn new habits, the position, how to obtain a image without moving the camera, the anatomy. The anatomy is very useful to do some dissection courses, cadaveric courses, but we don't have any legal problem because we are accessing the orbit. You can choose your tools. Nobody says that to access the orbit you can use transconjunctival or endoscopic. I think the endoscope is very useful for us. You can perform endoliftings, you can perform orbital decompression, lacrimal surgery. You have to begin with lacrimal surgery, it's the easiest part, but I think it's very useful for us.
Well, I just wanted to address Yuri's question about CAT scan and iodinated contrast material. Because CAT scans only rely on density, gadolinium can also be used in CAT scanners. And if someone has a severe iodine allergy, I don't know if the speaker has ever used gadolinium, but you can drop the gadolinium right down there.
Nice, as a drop force. That's interesting. Okay, our next talk was on management of orbital lymphatic venous malformations. Speaker from Portugal, Guillermo. Any questions for him? Go ahead.
So, given the risk of, it's not a huge risk, but of bleomycin, is anyone using sirolimus as primary therapy, skipping everything else, and just going straight to systemic therapy? And if not, why not?
It could be. We have the tendency to use in refractory cases and cases that have a lot of bleeding. But if it's a microcystic lesion, only a microcystic lesion, maybe we should start with sirolimus. I think it's a good option. Yes. But we have to wait at least 6 months, and sometimes there's a problem because the bleomycin works faster. And when you have an acute hemorrhage, you need sometimes to have to alleviate rapidly the lesion. So what happens sometimes is we don't have time to wait for the sirolimus, because I think sirolimus at least needs 6 months of treatment to see the effect. Sirolimus, yeah, it's very well tolerated. You have to check. We have an ocular immunologist that schedules this patient every 6 months. The liver and the renal function has to be checked, and also neutrophils, lymphocytes. But normally, we didn't have to stop in any patient sirolimus, so it's very well tolerated, I think.
Also, one quick question for you. In the US, it's really commonplace for interventional radiologists to practically do the whole thing, but they ask the orbital surgeon to be on standby in case they run into complications. Is that how it is in Portugal, or how you do this yourself? You do it with interventional, or how do you manage yours?
Yes, we do it both. We prefer to do it ourselves because we can find better the lesions, I think, with our orbital surgery experience. Sometimes we have to do it intrasurgically if the lesion is more behind the eye. We have to do it in the OR. So we tend to do it, and when we can, normally we do it percutaneously, and when we do it percutaneously, we do it in angiographic suites with them, and they help us with the fluoroscopy, because it's very important before injecting the contrast to see if it flows back to the cavernous sinus, because in that way we should be more careful and search for other sites of injection that doesn't reflow to the venous sinus, cavernous sinus.
Can you comment about the use of bevacizumab in combination with the bleomycin? Have you done that?
No, we don't have any.
Does it work? Do you know?
I don't know.
It would seem to be safer.
Yeah, I saw some papers, and yes, it seems we don't have any experience. Perhaps it would be a big. But I think the combination with sirolimus and bleomycin is a good therapy. Most of the patients that we do both, we have them stable. So I think it's a good combination.
And we now have Dr. Serpa virtually available. Any questions for him on ultrasound? Of course, he gave the presentation in Spanish, but I'm sure a lot of our audience was listening and understood. Any questions for him? Thank you for calling in. Thank you for a great presentation. Okay, now for the rapid fire sessions. We had several very good talks. Ultrasound and oculoplastics for fillers and cosmetic use. Any questions for Dr. Luna?
Ceci? In patients with migrated hyaluronic acid, you do anything more than hyaluronidase?
Sorry, can you repeat?
Si en los pacientes que tienen ácido hialurónico migrado, haces algo además de hialuronidasa. Porque algunos pacientes tienen rellenos muy densos.
La verdad que no, porque normalmente cuando no se resuelven es porque uno no está llegando específicamente al depósito. Entonces, si uno hace el tratamiento correctamente, en general, no hay problema.
Yes. No, she said that she only used hyaluronidase because the problem is when you don't reach the correct anatomic space to put the hyaluronidase. So the useful of ultrasound.
Is that a normal thing? You use the ultrasound for placement of the fillers?
I don't usually use it to place the fillers. I do vascular mapping before, and then I use, then I place it like usually. There's people who do it, but I don't usually do it.
My other talk later is going to be showing all the people that got blinded by putting these fillers in. So I don't understand why you don't use the ultrasound. In every other thing that vascular, they are using the ultrasound.
Yeah, you can do it, and it's okay. And for people who are starting, if they want to train doing that, it's okay. But then if you do know your anatomy, if you do map the vessels before and you know what you're doing, it's safe.
So you do? I am also using
I do map before, yeah.
So Andy,
MRI.
the vessels are matched before, it's just that the injections without. But you do mapping.
I do map before,
So you do
yeah.
mapping before you
Yeah,
inject?
I want to know where the vessels are, and then
Yeah.
I do my infiltration.
Huh, okay.
Okay, great. And then we had a talk on virtual reality for extraocular motility assessment by Dr. Chiaki, DeSantis Chiaki. Any questions for her? Sounds like it was an interesting way to, especially for remote and telemedicine assessment. And then we had a talk on trans eyelid crease approach for dermoid cyst, endoscopically done. I think it was presented from Italy. Are there any questions for that speaker, Dr. Ciccarelli? Go ahead. Atta.
about the use of the endoscope because she did a very large skin blepharoplasty style, lid crescents.
Yeah, it's a good question. Did it really make our incision any smaller? I think that's the question. I mean, it's a good way to get started using endoscopes. A deep orbit, for example, it would be nice. But is the speaker here? Yes. Yeah, please comment.
Hello, thank you for the question. In surgery, sometimes you discover things during the surgery, not before. But even if we saw the images in the MRI, we did that incision because the visible part of the cyst was just the point of the iceberg. The endoscopic solution was used during the surgical planning, not before. We didn't plan before the surgery to use the endoscope. It was an intraoperatory decision because we saw that the visible part of the cyst was just the one that went out, but inside there were more. And as I said, the incomplete removal of the cyst is the main cause of recurrence. That's why we used the endoscopic in a second moment. At the beginning, the incision was bigger. If the decision is, of course, pre-operative, the incision can be a little antrostomy.
Thank you. And then our final talk, I don't know if they're not here. We have a few minutes if Dr. Bedrosian is here and wants to present. Maybe he's not here. Any other questions for any of the speakers? Great. I think we're on time. So, Hatem, go ahead. One question. Yeah.
One concern about the bleomycin talk. Most of your lesions are still there, so it's just a matter of time before it gets. So just a difference between bactericidal and bactericidal.
It's still there, but we know of course, these patients can recur. We know that. But they get stable. That's why I think that's why I was saying that to add the sirolimus is a good option. Also, we see that lesions are there, but they are more fibrotic, less vascular. So I think they are like fibrotic or sclerosed because of the bleomycin. We see that they don't get contrast as before. They don't impregnate with contrast. So I think they are like fibrotic. But we don't know, of course, they could recur. That's why these patients have to be followed.
Great. Thank you for a great session, everybody. Yeah, one more question.
Do I see if we still have time till 10:30? Okay. So I'm very glad, Andy, always an entertaining and informative talk. You brought up the issue of the white-eyed arteriovenous fistula. And we have a similar parallel to white-eyed thyroid eye disease. Sometimes people put down the value of clinical activity score, saying that it doesn't work for every case. And that's what it's all about. It's the 80-20 principle in everything that we do. When something's been described, it works for a majority of patients, it does not work for a minority of patients. We should not put it down. So likewise, keeping that in the back of the mind in all of the differential diagnoses is extremely good. And glad to see a parallel there. And I know there's an ethnic variation in your AV fistula. It's a flow characteristic. But in thyroid eye disease, we see a lot of it as an ethnic variation of a silent eye disease or a white eye disease, what I call it silent active disease. So it's great to hear that. So when do we push the envelope to push for an invasive angiogram? That's something I always debate, and I'm stuck sometimes.
I think maybe Andy can comment. I think it's very important for the audience to know posterior outflow fistulas and the risk of stroke, and that's really why we used to just like watch these anterior fistulas for them to spontaneously close. Now we do an angio on everybody to rule out posterior flow. Could you comment on that?
Yeah, so both comments are really important. So the thing that's important from a neurop standpoint is not the red eye. The red eye is just the sign that something's wrong with the person. And to Yuri's point, in the Conyard classification of arteriovenous fistulas, including the carotid cavernous fistula, it is posterior venous drainage, retrograde venous drainage, venous ectasia, and high flow on the arterial side that are determining factors. And because if you have cortical venous drainage, you could get a stroke or a hemorrhage and die from your red eye. So don't listen to us of the past where we told you you could just watch carotid cavernous fistulas and that's fine. Without an angiogram, you can't see the Conyard 2B. So that's the letter and the number I want you to remember. 2B or not 2B, that is the question. Anything above Conyard 2B is retrograde, venous ectasia, and the possibility of venous hypertension. And if you have cortical venous drainage, you are above a Conyard 2B, they might die while you're watching their red eye. So it's not about their eye at all. And the only way, as Yuri mentioned, to see if it's a Conyard 2B is a standard catheter angiogram.
Also tell us how urgently you got to get a CT angiogram in a red eye, and how about just like an asymptomatic suspected dural fistula or something? You just tell us about the timing. How much pressure do you put on?
So you got to talk to the person first. So the symptoms, if they have any symptoms of intracranial hypertension, headache, double vision, you got to admit that person. The asymptomatic red eye person, you still don't know if it's cortical venous drainage, but it's not an emergency, but you kind of got to move along. So don't listen to anything that people like me said to you about just watching these, as Yuri said. You don't know what's in their head. The only way to know that is a catheter angiogram. But to your point, it's not an emergency unless they have neurologic symptoms, symptoms of venous hypertension, headache. It's just, don't fool around with that either. Yeah, a week, yeah. But really, we have gone to just dumping it on other people because you don't want to be the one. You didn't do any neurologic exam. I don't take anybody's shoes off in my clinic. So we're not measuring anything in these people. So I think it's a team. There is no I in team, but there's a definite I in team, and you're that, okay?
And I think that's a huge paradigm shift, because I was taught as a resident, just watching a lot of them close, and arteriography is extremely safe. We ran everything.
I think that's a really important point here. Don't listen to that. This is not your father's CC fistula anymore.
Great, thank you so much. I think we're now done with the session and on to the next. Let's see, who's chairing the next session? Let's invite them up here. Is it Luigi?